Good evening, everyone, to our 156th webinar on diabetes and pregnancy, including gestational DM, that is diabetes mellitus. And we have no other than our Alka ma'am, who's going to be the speaker for this webinar. So we all know Alka ma'am needs no introduction, and we thank her so much for taking up this webinar today. Ma'am, over to you.
Thank you and good afternoon, everybody. Shall I start?
Yes, ma'am, we can start.
Okay. Why are we talking about diabetes in month of November? As you all know, that 14th of November is observed as a World Diabetes Day all over the world. When we observe a day like this, it is only meant to take stock of the situation, what we have achieved so far and what remains to be achieved. And there are a lot of things which are changing in the life of diabetes and in the course of diabetes. And therefore, we need to go ahead and take care of our population. Therefore, I have chosen a small subset of diabetes and pregnancy. Now, what is the scenario of diabetes in India? As you can see here, this is a paper, this is ICMR study, which is just published in June 2023, DM endocrines, and they have given that at present in India, we have diabetes, the number of diabetes is 101 million, more than 10 crores, and more than 13.5 crores are pre-diabetic. So you can see the burden of diabetes in our country. And at least 40% of this will be women. Some of them will be in the reproductive age and they will conceive. And what are going to be the effects of this on the society and on women and the fetus? That's why diabetes in pregnancy is quite an interesting as well as challenging topic. As family physicians, family physicians are the members, like members of any family where you are a family doctor. And therefore, I would appeal to all of you to spread this knowledge to all the families. And whenever there is a marriage in the family, you should tell the seniors in the family that after the marriage ceremony, at leisure, they should send the couple to you for some discussion on some of the issues related to conception. And one of them will be, of course, diabetes. Now, diabetes, though we are talking today in 2023, has been known since ancient times. Hippocrates has written about it. Charak and Sushruta has written about it. Ayurveda has actually given a very vivid description of diabetes. They have called Madhumeha, which is diabetes. They also identified Udakameha, that is diabetes insipidus. And I'm really surprised that for want of tools, how could they make all these observations? Mere observations and simple tests, and they could identify or they could label this Madhumeha, Udakameha, which today we recognize as diabetes insipidus, Ikshumeha, that is renal glycosuria. Not only that, Charak has written that there are two types of diabetes. One is type 1 that we call, which occurs in the young people, and type 2 diabetes, which previously was known as maturity onset diabetes. They have also written that because this disease has a genetic basis, that it is incurable. And even today, we are struggling to cure the disease. We are talking about remission of diabetes, but cure is still out of sight. So it is a very important non-communicable disease. It is a lifestyle disorder, and therefore all of us should be aware and should be talking about it. Now, although it was known, now Charak was about 500 BC. Hippocrates was around 350, 400 BC. Since that time, we knew about it. Many medicines were tried for this, but real breakthrough came when Paul Langerhans in 1869 identified islet cells of pancreas, but he could not detect the function of this. But he showed the ray of hope. And then the research continued, and it was in 1921-22 that anti-diabetic hormone, that is insulin, was used in dog. This was based on Banting, and actually this was purified and used for commercial use in 1925. So you can imagine from 500 BC to 1925, that means it took about 2,500 years to come to the discovery of insulin. Although insulin came so late, there was a Jocelyn clinic in US which was studying diabetes, and as early as 1949 they have put down their observations, and they have given the pregnancy outcome in diabetes. They have said spontaneous abortion 25%, fetal loss 18%. Of this fetal loss, 80% were stillbirths. That means the child was born where it was stillbirth, 75% neonatal deaths, and there was a macrosomia, overweight baby with metabolic instability in 80% of the newborns. And this is what Priscilla White has published in Jocelyn Clinic. 1949, imagine. Since then, we have been studying about this diabetes and its effect on pregnancy. For a moment, we keep aside diabetes and let us see what happens during a normal pregnancy in a non-diabetic mother. Now, the fetus is totally dependent on the mother for the nutrients, be it glucose, amino acids, or fat. Everything is receiving from the mother. Oxygen, the fetus is receiving from the mother. And what is a fetus? It is a new human structure, de novo, arising during pregnancy. Okay, so it is something like a foreign structure. It's a tissue, foreign tissue, which is developing, which is maturing in the woman's womb, and will be expelled out at completion of gestational period. We know that whenever there is a foreign tissue in the body tries to react to it and tries to expel it, what we say rejection. If we do kidney transplant, we are worried about rejection of the transplant. Similarly, this rapidly growing tissue transplantation, that is the conceptus, can be rejected. And that is why nature has also given certain natural phenomena, like there is immune suppression in a pregnant mother. There are metabolic changes and there are hormonal changes. Okay, so it alters maternal fuel metabolism, alters the hormones in the mother, and this is also facilitated by the placenta. There is an increase in estroprogesterone, which causes beta cell hyperplasia. Naturally, when there is a beta cell hyperplasia, there will be increase in fasting insulin. There will be decrease because of the increased insulin. There will be decreased in the fasting blood sugar. The decrease in the fasting blood sugar is not only because of the increased insulin levels, but also because there is an increased plasma volume in the early pregnancy. Also, there is a fetoplacental glucose utilization, therefore fasting hypoglycemia. And in the later pregnancy, insulin being an anabolic hormone, there will be a growth of the child and there will be anabolic effects of this insulin seen. I showed you a study of 1949, and this is a study, CMASH study 2002, and you can see stillbirths, perinatal deaths, and neonatal deaths in type 1 and type 2 diabetes, and they are almost similar. Okay, so we have to control diabetes and protect the fetus. Now, when we talk about any pregnancy, we are worried about mother, we are worried about the fetus, and also the pregnancy outcome. Let me take you back to the diabetes. What are the risk factors for diabetes? It's a lifestyle disorder or non-communicable disease, multifactorial, heredofamilial, Obesity is the greatest risk factor, and sedentary work style is, that means lack of exercise, is a risk factor. What are the complications if there is a diabetes in pregnancy? Fetal and neonatal deaths, congenital malformations of the fetus, preterm deliveries. It can lead to preeclampsia, macrosomia, overweight baby. Because of all this, increased need for cesarean section and maternal mortality. So see the complications of diabetes in pregnancy. Why congenital malformation? There is a maternal hyperglycemia, which also goes to the fetus. There is a metabolic substrate, increased oxidative stress, increased free radicals, mitochondrial swelling, and that causes the DNA damage. And because the DNA is damaged, there will be congenital malformations. Nowadays, as I told you, that the family physicians are like a family member. And therefore, whenever there is a wedding in the family, please tell the elderly people to send the couple to you for a counseling. Do an extensive preconception counseling. Before the couple is ready to conceive, they should be physically healthy and psychologically prepared to accept the parenthood. Both of them should be healthy, and therefore there should be a couple counseling. We should also do their CBC, urine examinations, blood sugar fasting PP, HbA1c, serum creatinine, examine the blood group, blood VDRL, also test for HIV 1 and 2, HBV, that is HBsAg, HCV, anti-HCV antibodies, so that if there is anything, we can treat them, correct them, and serum TSH. Because as you know, the TSH levels during pregnancy are different, and we have to take care of the high TSH levels during pregnancy, and the X-ray chest. Because once they get pregnant, once she gets pregnant, we wouldn't like to expose her to the X-ray. Therefore, X-ray chest of the mother should be done. Because many times, I need not elaborate on this, but TB may remain silent. The TSH levels, I have already talked to you. The TSH level parameters for pregnancy are different than the normal. If there is HbSAg, which remains asymptomatic, and therefore you have to prepare about the immunization. If the mother is positive, then we have to prepare for giving immunoglobulins and immunization of the child. And therefore, all these investigations should be done before they conceive. So the only principle is mother and the father, would-be mother and the father, should be physically, mentally, psychologically be healthy and prepared for a parenthood. If there are any vaccinations to be given, then the vaccination should be given before pregnancy. In pregnancy, which are the vaccines which are contraindicated? The vaccines consisting of toxoid, killed bacteria, killed viruses can be given because they are safe. But vaccine consisting of attenuated viruses such as mumps, measles, rubella are contraindicated during pregnancy. So also vaccine for yellow fever is contraindicated. So vaccination during pregnancy, preconception counseling, we do HBV diagnostic, we can, if they are negative, we can give HBV vaccine, we can give hepatitis A vaccine because it is almost endemic in India. We can give swine flu vaccine, COVID-19, we can give tetanus pertussis. The slide is not seen properly here. And vaccines which should not be given are MMR, varicella, yellow fever, and BCG also should not be given during pregnancy. Now I come to diabetes and pregnancy. Diabetes may be present before pregnancy. Now, if it is present before pregnancy, it may be type 1 or it may be type 2. Both of them will have different treatments, isn't it? So what should we do? Now, mother is a known diabetes. So she requires a comprehensive preconception counseling. She has a lot of tension. She is worried about the child which is going to grow in her womb. So we have to tell her well-controlled blood glucose and HbA1c. Diabetes management during pregnancy and labor has to be looked after, and of course the postpartum care. So preconception counseling, that should be couple counseling. First of all, the lady has to accept and adapt to the new lifestyle that she is diabetic and she is going to conceive. So education regarding diabetes has to be given. Lifestyle modification has to be told to her. Medical nutrition, psychosocial evaluation. We must also teach her self-monitoring of the blood glucose. Most of the patients, they do not even know. So self-monitoring of blood glucose, medical assessment should be done, glucose control prior to the conception, and therapy modification. Now, what is the therapy modification? Before that, lifestyle modification. If there is a high BMI, reduction of weight. Time management. What is most important is the regularity of the meals. Working pattern, again, has to be a very regular pattern. You see many women who have night shift, they are irregular with their foods, and therefore there will be problems of controlling the blood glucose. And therefore we have to make the changes in their working pattern. Avoidance of stress, no smoking, no alcohol, no substance abuse. You may laugh at me what madam is talking. In India, smoking, alcohol and substance abuse, please keep your eyes open and look around. I used to only see our class 4 women, Safai Kamgar in our hostels and in the hospitals. They used to smoke openly. Now I see a lot of young girls all around on the roads. I mean, the boys with whom they are standing, the boys are not smoking, but the girls are smoking. Alcohol has become very common, also the substance abuse. And therefore, they should be told about all this. Psychology, psychosocial evaluation, acceptance of a disorder. Yes, I have a diabetes. I have to live with it. And if I have to live with it, I have to take my care as well as the care of my child. Their attitude towards diabetes should be positive. We should also counsel them about the expectations of quality of life. If need be, there should be a structured psychotherapy, and if need be, structured psychopharmacotherapy. So if you feel, then you can take the help of a psychiatrist to tackle these problems. Exercises. She should do regular exercises. And the best exercise is just walking. Avoid supine position. Avoid risk of imbalance. Avoid fall or fetal trauma. Aerobic exercises are contraindicated. Please remember that. And therefore, the best exercise before the conception and during the pregnancy that she can take is walking exercise. Now, she is a known case of diabetes, and therefore, before that, I would like to get a CBC, blood glucose, fasting, as well as post-lunch. And remember, the fasting and in a known diabetic, the fasting and post-lunch should be done on 2 different days, because we are going to do them along with their medication that they are taking. So if you do fasting today, many laboratories I have seen, they say, nahi, khali pet ana. So हमारे patient जाते हैं खाली पेट. They go, the laboratory opens at 9 o'clock. 9 o'clock they give the blood. Then the technician say, अभी जाके नाश्ता करके आओ. So they go outside, eat vada pav, samosa or something like that, and they come back. This is absolutely wrong. We have told them about diabetic diet. We have told them about what they should eat for the breakfast. We have also told, if they are on medication, whether insulin or oral hypoglycemic, that they have to take it before breakfast. Now, all this is avoided. And then we get wrong reports about their blood sugar level. So please remember, if you want to know fasting, do fasting today and post lunch tomorrow, 2 hours after the lunch. And that also along with medication. HbA1c, which gives you the idea of the control in last 3 months. Serum lipids. Now, because of pregnancy, there is risk of retinopathy also increases. So do a fundoscopy. Diabetes and hypothyroidism is quite common. They are great friends together. So do serum TSH, and as such, we have to manage TSH during pregnancy. TPO antibodies to see whether there is a real hypothyroidism, which is autoimmune. Serum ferritin levels and microalbuminuria. Why? Because these are known diabetes of certain duration of time, and therefore we want to see whether there are other organs which are affected. What are the therapy modifications? Type 1 will be receiving insulin only, but the type 2 may be on the oral anti-diabetic drugs. These oral anti-diabetic drugs, next slide I'll show you, but they are not preferred in pregnancy. And therefore, we have to switch to insulin therapy. So before conception, type 1, continuing on insulin, but see that the blood sugar is controlled. Type 2, switch them to insulin therapy. If along with that, if they are on ACE inhibitors, stop them, omit ARBs, and stop lipid lowering agents, statins, which are contraindicated during pregnancy. What are the glycemic targets before conception? Pre-meal blood sugar should be 80 to 110. 1 hour postprandial blood sugar should be 100 to 155. 1 hour I am saying. And HbA1c should be less than 7. But also remember, it should be as close to normal as possible without resulting into severe hypoglycemia. So we must avoid hypoglycemia at any cost. Okay, so this should be the target before conception. Now preconception, this is little sophisticated. If you have a sophisticated couple, we can do the basal body temperature monitoring. So we know exactly the ovulation time. At that ovulation time, once we know, they can take a chance for conception, and then monitor the blood glucose 6 times a day. The glycemic target, assuming the pregnancy, we should have our glycemic target, which I've just shown you in the previous slide. Oral anti-diabetic drugs are not to be used during pregnancy. Tolbutamide, chlorpropamide, glibenclamide, glimepiride, all of them, they act on the beta cells of pancreas to release the preformed insulin. And they are long acting. And therefore, they can cause hypoglycemia at any stage. Also remember, in early pregnancy, excuse me, sorry, I have a bad throat. In early pregnancy, there is hyperemesis. The food intake of the woman is irrational, irregular. And therefore, these long-acting anti-diabetic drugs, oral hypoglycemic, are not to be used. Recently, there are some papers favoring metformin. Yes, but again, we have to be very cautious when we are using, because metformin causes nausea, a metallic test, so food intake will be reduced, and in some people it may also cause diarrhea. So it is better to avoid it. OHA in pregnancy, inadequate safety data, lack of controlled trials. There is a long duration of action, non-flexibility of dosing, contraindicated in Europe and United States. 2008 reference I'm giving you. So we should not use them. Okay. We can give what is flexibility. You can monitor the blood glucose, and based on that, you can give the regular insulin. Insulin is the gold standard. It's established efficacy. It is established safety, and it is unable to cross the placenta. Therefore, there is no worry about hypoglycemia in the child. Insulin, start short-acting insulin. I'm just telling you the types of insulin. There is a short acting, which is also called as regular insulin. Some of the old people may remember plain insulin. So it is a short acting. The duration of action is about 4 to 6 hours, and therefore we have to give it 3 times a day. It is a regular insulin. What are the types today that we have? We have a human insulin, which is short acting. And there is a synthetic insulin, which is Lispro and Aspart. These are again short acting. So in short acting, we have human insulin and we have synthetic Lispro or Aspart as short acting insulin. Then intermediate acting, we have a human NPH. And then we have synthetic insulins. And all of you know these are called as basal insulin. Lantus, you all must be aware about this. So these are one injection to be given at bedtime. However, they have not been cleared by FDA for use in pregnancy. Just last week, I got information that Ditemir has been cleared, but I am not very sure. But I would not like to use them in pregnancy unless I get a lot of data of its safety. So we can use only these regular insulin and we can use the NPH insulin. What is the insulin requirement? This is roughly I am telling you. It is 0.6 units per kg per day. So if the woman is about 50 kg, the insulin that she requires per day will be 30 units. And these 30 units you divide based on her intake at breakfast, lunch. So insulin dose should be little more for the breakfast and lunch, and it should be small at the dinner time, because we don't want her to go into hypoglycemia during night. In the first trimester, the dose is 0.7 units. In second trimester, 0.8 units, because she goes on increasing her weight gain. Then third trimester, 0.9 units, and at term, it is 1 unit per kg per day. During labor, the NPH dose at previous night is given, but there is no subcutaneous insulin we will give on the day of labor or on the day of C-section. Normal saline infusion should be started. 1 hourly blood glucose, regular insulin boluses should be given depending on the blood glucose. Active labor, when the active labor starts, glucose infusion plus insulin should be started. Now for all this, I would suggest that it is an anesthetist's responsibility, and we should also consult a diabetologist to maintain the normoglycemia during labor and C-section. Now, after the delivery, now nursing mother, her caloric requirement will be high because she is feeding the baby, and that will be 27 kilocalories per kg per day. At the same time, we will have to reduce the dose of insulin, and as you can see, we can start 0.6 units per kg per day. Of this, 5/6 is the dose which is given. We start as daily dose, okay, not the full dose. So if I get 12 units, I don't start. If I get what we say 50 kg woman, 30 units. So I don't start with 30 units. I start 5/6. That will come to about 25 units. Okay. Now, all this is going on about type 1, type 2, which is already present, which we are managing, which we are controlling before conception and during pregnancy, also at labor and C-section. It was in 1964, O'Sullivan and Mahan, they described impaired glucose tolerance. That means if you give a lady some glucose load, the sugar will not be controlled. If you are a normal person and if I give you 75 grams of glucose, at 2 hours your blood sugar will be normal, because if there is a glucose load, there will be increased level of insulin, and that will bring down the blood sugar. But if your pancreas are affected, or if there is some problem, there will be impaired glucose tolerance or hyperglycemia. So they described impaired glucose tolerance or hyperglycemia in pregnant women who were not known diabetics. That means they were not known diabetics. They were normal women. However, during pregnancy, when he tested, he found that impaired glucose tolerance, or some women also had raised blood sugar level, and he is the one for the first time gave the name gestational diabetes. That means diabetes which occurred only during pregnancy. Okay, so gestational diabetes we came to know from 1964 onwards. So GDM is typically a temporary condition that occurs between the 24th and 28th week of pregnancy and usually resolves after childbirth. Resolves after childbirth. Therefore, we say it's a temporary condition. Doesn't occur in the first trimester, occurs in the second trimester, so 24th to 28th week. So it is only related to gestation, and therefore it is called a gestational diabetes mellitus. All right. So by definition, I defined GDM. Just 1 minute. I defined GDM. So DM detected during pregnancy, gestational diabetes. But the diabetes which was existing before conception, whether type 1 or type 2, it is called as pre-GDM. Pre-GDM, pre-gestation. What is the prevalence of GDM in India? It depends on various factors. It depends on factors which I'll tell you in the next slide. Prevalence is 4.2%. This was a study which was done. How can I get rid of this? This was a study recently done, and sample size, this was ICMR study, 28,408 pregnant women all over India, from house to house survey was done. And from this house to house survey, we found that 1 in 25 women have GDM by just doing a random blood sugar. 1 in 25 women. There was a low burden in Northeast, higher in Central, Western, and Southern India. The prevalence, overall prevalence is 4.2. But in the younger age group, 15 to 24, this is the age of the mother, it was 3.67%. But as there is increase in the age, more than 35, the incidence goes to prevalence increases to 6.41%. Now, pregnancy induces progressive changes in the maternal carbohydrate metabolism. As pregnancy advances, insulin resistance and diabetogenic stress due to placental hormones necessitates compensatory increase in insulin secretion. However, if the compensation is inadequate, then the gestational diabetes develops. What are the risk factors for gestational diabetes? Advancing age at conception. And nowadays you see, at least in the urban area, many girls, they are becoming career minded. They postpone their marriages, they postpone their conception. And so advancing age is a risk factor for GDM. Obesity is another one. PCOD. PCOD itself indicates that the girl had been obese. So that also is a risk factor. Previous history of GDM, parity, and as the parity increases, the chances of GDM increases, and family history of diabetes. So if these are the risk factors, we must test these women for blood sugar. Now GDM is beta cell dysfunction. There is a delayed response of insulin to glucose load. And why it is so? The placental hormones, they cause insulin resistance. Placental hormones like placental lactogen, growth hormone, prolactin, and cortisol, which are secreted in the later part of the pregnancy, they will cause insulin resistance, and therefore the gestational diabetes develops. In addition, of course, obesity and other risk factors, which I have already told you. How do we diagnose gestational diabetes? The blood sugar estimation is done between 24th and 28th week. Ideally, it should be 24 weeks. So 24 to 28 weeks. Now, it's very difficult. It all depends upon the accessibility of the health center. In India, in many parts of India, underdeveloped, tribal areas, these people don't have health facilities. Even if they have, the ladies are shy to go and show to the doctor. So it is usually very late in the pregnancy that they go to the health center. Secondly, if we want to do a glucose tolerance test, giving fasting and then giving a glucose load and doing it, collecting the blood 5 times in 2 hours, naturally she will have to shell out money for all that, and that is another finances or expenses is another restricting factor. And therefore, there was an international association for diabetes in pregnancy study group. They have given their recommendations, IADPSG, International Association for Diabetes in Pregnancy Study Group. And we had our own group, Diabetes in Pregnancy Study Group in India. All right. So I am giving both the criteria to you. Fasting, if it is more than 92, it is GDM. If 1 hour blood sugar is 180, it is GDM. If 2 hour blood sugar more than 153 is again GDM. So International Association gives you 3 levels, I mean 3 parameters. So if the patient comes, you collect fasting, then give a glucose load, and then do 1 hour, 2 hours. The glucose load is 75 grams of oral glucose. In India, it is not feasible. It may be expensive to do 5 samples, and therefore, what the Indian group advises, 2 hour post glucose more than 140, it is GDM. You give glucose, 75 grams of oral glucose, and then collect blood only once, that is 2 hours. If it is more than 140, that is GDM. The patient may come in a fasting state or non-fasting state. In both the cases, give 75 grams. And if the beta cell function is normal, there will not be impairment, blood sugar will be normal. But if it is more than 140, it is GDM. What are the complications of gestational diabetes? Birth injuries, shoulder dystocia, which is quite common with this, macrosomia, overweight baby, and all this will again result into a C-section, and that will be again expensive for this woman. What is the management of GDM? The management of GDM is simple. It is called as medical nutrition therapy. Exercise. Exercises, as I told you, I have already told you, no aerobic exercise. Avoid supine position. No imbalance. We have to protect the child. So the best exercise is walking every day for 40 minutes. 40 minutes at least 5 days a week. Okay, that is the safest exercise that they can have. And if with medical nutrition therapy or exercise, it is not controlled, or if the fasting blood sugar is more than 120, we start medical nutrition, we start exercises, but if it is more than 120, insulin has to be started. Okay? Medical nutrition therapy. What is medical nutrition therapy? Like any other diabetics, what we'll have to do here? Carbohydrate restriction. So carbohydrate controlled meal plan. American Diabetic Association advises less than 40% of the calories should come from the carbohydrate. less than 40%. Otherwise, 60 to 65% of our calories, 55 to 60% of our calories, total calorie requirement comes from carbohydrate. So in pregnancy, with GDM, it should be less than 40%. In India, there are no uniform guidelines. Plus, we are vegetarians, and therefore, our leaders have said 45 to 50% from carbohydrate. What is most important is small, frequent meals. So it should not be large meal at a time, because a large meal will again cause a rise in the blood sugar, which takes time to come down. So small, frequent meals, which also prevent the hypoglycemia and keeps the blood sugar at a constant level. We should also test the pre-breakfast urine for ketones. And you will ask me why? Fasting blood sugar more than 120, we are giving insulin, then why are you worried about ketone? This is something called as a starvation ketosis. Okay? Because the carbohydrate intake is less, and therefore we have to see whether she is going into ketonuria. So we should do the urine for ketone testing pre-breakfast. Please remember that. Sorry. Now, what is the recommended weight gain in pregnancy according to pre-gravid BMI? Before conception, what was her BMI? And during conception, how much weight that she is allowed to gain? You know, our pregnant ladies, the way they are fed by mother and mother-in-laws and their husbands, and they are pampered. So they go on putting on weight. Okay. So here, because if they gain too much of the weight, that will again imbalance or impair the glucose tolerance. And therefore, we have to be careful. So pre-gravid, if the BMI, kg per square meter of the body surface, if the BMI is less than 19.8, BMI less than 19.8 before conception, this lady is underweight, and therefore she has a margin of weight gain from 12.5 to 18 kg in 9 months of pregnancy. Followed? Normal BMI 19.9 to 26. So this normal lady with normal BMI, she can gain weight from 11.5 to 16 kg. If the BMI is 26 to 29, she is overweight, and therefore she should not gain 12 and 18 kgs, but her weight gain should be 7 to 11.5 kg. And if her BMI is more than 29, she is obese, and therefore her weight gain should be less than 7 kgs during pregnancy. What are the blood glucose targets in GDM? The fasting venous plasma, once you have started treating either with medical nutrition therapy or with insulin, the fasting venous plasma should be less than 95. I am saying fasting venous plasma. So it is not the capillary blood. Okay. So from the venous blood, it should be less than 95. 1 hour postprandial less than 140, and 2 hour postprandial should be less than 120. The HbA1c should remain less than 6. So this is how we are going to manage the gestational diabetes, and these are the targets. What are the postpartum considerations? Now, if this lady had gestational diabetes, is she going to remain diabetic? I said it is temporary. It reverts back to normal. However, there is a very high chance that this lady may go on to develop type 2 diabetes, and development of type 2 diabetes varies from 3 to 70%. Development of T2 diabetes after delivery varies from 3 to 70%. Therefore, test the mother at 6 weeks postpartum. Thereafter, 1 year, if indicated. What is the indication? Obesity, family history of diabetes, test every year. If not, then development, then you can test. See, high risk is obesity, family history of diabetes. But if this high risk is not there, then otherwise, every 3 years, her blood sugar should be tested because she is likely to develop type 2 diabetes. What about the child? The child, as such, because of GDM or diabetes, pre-GDM, has been a macrosomia, overweight baby. And if we keep on feeding this baby, the child is likely to develop childhood obesity. And today that has become the biggest problem for us to control the childhood obesity because they are likely candidates to develop diabetes. So I think that is all that I wanted to share with you. So please don't take it lightly that this is diabetes and can be managed easily. We manage so many patients. Yes. But when we manage a pregnancy and diabetes, there are 3 things we have to keep in mind. The mother, the fetus, oblique newborn, and the pregnancy outcome. We want them to go safely through all these. We don't want abortions. We don't want preeclampsia in the mother. We don't want other complications, ketonuria and retinopathy in the mother. And therefore, please manage them properly with medical nutrition therapy, insulin whenever is required, whenever fasting blood sugar is more than 120, otherwise medical nutrition, and please motivate them for walking exercise. Okay, so this is gestational diabetes, which develops from 24 to 28 weeks of pregnancy in a non-diabetic woman. If the diabetes is present before the conception, it is pre-GDM that is present before the pregnancy. So that is all I wanted to share with you. Thank you very much for your patient hearing.
Thank you, ma'am. Thank you so much for the session. Thank you everyone for joining. See you next week. Thank you.